Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, the Société Francophone de Nephrologie Dialyse et Transplantation, and the Junge Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Professor Romain Didier in Brest, France, and Professor Behnood Bikdeli in Boston, Massachusetts, with whom we would like to discuss extended treatment of provoked venous thromboembolism, VTE, focusing upon Dr. Bikdeli's HYPRO study, which was presented at the 2025 European Society of Cardiology meeting as a late breaker and published in the New England Journal of Medicine simultaneously. Dear Romain, thanks for joining us for the first time. Dear Bennett, happy to have you back at home after our 2021 webinar in the midst of the pandemic.
Thank you.
Thank you very so much for having me. It's wonderful to connect with you again, and I appreciate it.
Dr. Romain Didier is cardiologist and professor of medicine at the University Hospital of Brest, France, and he is PI of Aquatic, which we will discuss in a separate webinar. Dr. Behnood Bikdeli is cardiologist and clinical investigator at Brigham and Women's Hospital and Harvard Medical School. His work focuses on thromboembolic and vascular diseases, including deep vein thrombosis, pulmonary embolism, and antithrombotic therapies. He is internationally recognized for his leadership in cardiovascular and thrombosis research. Today, he is focusing on the HYPRO study, which investigated extended anticoagulation with apixaban in Provoked, VTE. Thank you for joining us again at Marcus at Home.
Thank you so much. So I would love to share a brief summary about HYPRO with you, but more importantly, I want us to have some time to discuss more about it. And it would be absolutely unfair if I didn't start off by giving credit to my dear friend, mentor, and colleague, Greg Piazza, who was really the mind behind this study. The study is funded by BMS Pfizer Alliance, but I have no personal disclosures for the trial. And the first question is, why HYPRO? I think part of the reason Greg thought of this trial is we've had a lot of interesting information in terms of shared decision-making with patients, having good tools for patients with unprovoked venous thromboembolic disease. Even more recently, with cancer-associated thrombosis, there were a host of trials that informed us more. But for patients with provoked venous thromboembolic events, meaning there was a major transient provoking factor, the historic classic teaching has been, okay, it was transient, do short-term anticoagulation and you're done. But at bedside, we sometimes found the opposite, meaning the patients had provoked events, but along comes another recurrent event. So what do we do? And it's really not good to make a guess. So we thought enough is enough. Let's design a randomized trial and try to answer this. The next question is, why did we do it as a single center randomized trial? It's rare that you do a clinical outcomes trial, meaning you power the study for a hard clinical outcome, and still you do it at a single center. Challenge is there were considerations for funding, logistics, etc. And we saw that for pragmatic purposes, there would not be a realistic chance that we can accomplish this clinical trial if we were to aim for a large multi-center, multinational trial because of all the difficulties with coordination and requirement for much larger funding. So perfect is the enemy of good, but we tried to settle for good. We randomized 300 patients to low intensity apixaban and 300 to placebo in those who had provoked venous thromboembolic diseases, but also very importantly, they had at least one enduring risk factor. And what are those kind of enduring risk factors? So we were talking about things like continued immobility, obesity, cardiopulmonary diseases, chronic kidney disease, or very important, inflammatory or autoimmune conditions. And of course, COVID came along the line. So in people who had clinically relevant forms of COVID, and many of them that also constituted a form of enduring risk factor. And all these patients could or could not have atherosclerotic cardiovascular disease as well. But by design, we restricted that subset to a max of 30% of enrollees. And these patients were randomized to low intensity apixaban 2.5 milligrams twice daily versus placebo twice daily for a total of 12 months for primary effectiveness outcome of recurrent symptomatic venous thromboembolic events. We, of course, assessed major bleeding and clinically relevant non-major bleeds, death, etc. As well. And this is the top line results. As you can see, there was an overwhelming benefit with apixaban compared with placebo, with more than 80% relative risk reduction. In the placebo arm, the absolute cumulative incidence of events was close to 10%, which is of course higher than one might expect from provoked venous thromboembolic events, but probably part of it has to do with the fact that many of these patients had enriching enduring risk factors, to the extent that the numbers to some extent seem similar to those of unprovoked venous thromboembolic events from prior systematic reviews and meta-analyses. But suffice it to say that even if the placebo arm event rate was a little lower, you see the magnitude of difference is so dramatic that it wouldn't have affected the results in a consequential way. And reassuringly, there was no significant difference in major bleeding. Major bleeding events were indeed very, very rare, and there were no fatal bleeding events. Although we did not see a difference in clinically relevant non-major bleeds, I have to suffice with saying that the study was not powered for clinically relevant non-major bleeds. The signal was there, and my best interpretation, now putting back my clinical hat on, would be that when you put someone on an anticoagulant, it's reasonable to expect some degree of bleeding, and always consider that in shared decision making. Key, as we did not observe fatal or fatal bleeds or a major signal toward increase in major bleeding events. Love to discuss more with you.
Thank you for your short presentation of your study results. Dr. Didier, would you like to start our discussion?
Yes, of course. It's a very nice trial. Thank you for presenting. I like it because it's very solid. The follow-up is perfect. Lot of good points. But for our colleagues, I want more details on what is the profile of the patient in terms of risk of recurrence. You mean it's low or intermediate or high risk of recurrence in your population?
That's a very good question. I think for the very population that was studied in HiPro, there is no absolutely validated algorithm. If you go by the most recent publication from European Society of Cardiology guideline, they do have color-coded gradients, low risk, intermediate risk, high risk. They put these patients kind of in the intermediate bucket, but even intermediate, it's really a spectrum. So even one of the things that we are trying to investigate as we speak is whether within this very population that we enrolled in HiPro, there is some heterogeneity in treatment effects, such that if someone has 3 or 4 of these enduring risk factors, there is probably greater absolute benefit from this low intensity anticoagulation, as opposed to someone who only has 1 enduring risk factor.
Thank you. And it's the opposite way. How you will define the bleeding risk of your population? Low or something like that? Or?
I would say not necessarily low, meaning we did not exclude people who would have a bleeding risk. For example, chronic kidney disease was actually one of the risk enriching factors in the study. But of course, if they had recent intracranial hemorrhage or if they had major bleeds within prior 30 days, those would be serious issues with consideration for treatment adherence. Those wouldn't be patients who would truly reflect being able to be randomized in a practical way, such that if there were to be a treatment effect, we would be able to pick it up. But they were not intentionally picked up as low bleeding risk individuals. I would probably say also moderate risk of bleeding was permissive, even though some patients would have been low risk.
So did this study change your practice, you mean? So you will now prolong the treatment, that's right?
That's one of the most interesting questions, and one that's really near and dear to my heart, because as we discussed, we did this study as a single center study. And when I was seeing my own patients, or my colleagues were seeing them, my pitch to them was, you're not really doing this for me. You're not doing it for necessarily merely for others, but you are doing it such that we, in a couple of years, would be in a position to help you have better recommendations for your own care. So absolutely, I think it is an informed care for our patients, and it helps them be in the driver's seat to make more informed decisions for their very own care, given the results of the study.
Okay, so I believe you dedicate the treatment for each patient, or also according the years, because when you start the treatment preventive to avoid the recurrence of PVE, so you start, and then after 5 years the patient have another event or low bleeding, so you change. I think you change.
Exactly. We monitor these patients periodically. And of course, many of the factors that we consider in statistical terms are time-varying covariates. For our audience, for example, someone might be very obese at the beginning, but what if they exercise and they change their diet and they adhere to many other recommendations, or they take one of the new classes of medications, and now they're in perfect shape, and they had a lot of unstable cardiopulmonary conditions, but now they're perfectly healthy. So really, it's not a one-size-fits-all. But I think the data gave us a lot more confidence that in the right setting, this treatment has effectiveness. So if there is no prohibitive risk of bleeding, it's very reasonable to consider this for the patient population that we studied.
Okay, thank you. It's more clear. And so I have one point, because I'm a cardiologist as well. So I see in your population that is also a high risk for cardiovascular disease. So it's like 12% of diabetic patients, hypertension, coronary disease, and 20% of patients are on aspirin. So that is very interesting. So we are borderline between cardiovascular disease and PE. So sometimes we don't know how to manage this patient. So in daily practice, when you have a patient like this, and you have a PE and also stent, for example, will you choose to stop the aspirin and give apixaban low dose as antiplatelet-like therapy, or you continue both? What will be your point of view?
This is such a wonderful comment, and I think we will come back to this when we will be discussing your aquatic as well. But bottom line, I want to share 3 or 4 quick points for our audience, and then I'll come back to your question. We know from studies within the past 2 decades that biology is really more complicated than the prior thought of white clot, red clot, arterial versus venous. Even aspirin confers relative risk reduction for primary prevention of venous thrombosis. We have multiple trials in orthopedic surgery. And even after regular venous thrombosis, there are 2 large-scale randomized trials between 60 to 70% relative risk reduction for secondary prevention. So if you have a patient who, for whatever reason, doesn't want to take anticoagulants, low-dose aspirin is better than nothing. Even P2Y12 inhibitors confer some relative risk reduction, separate conversation for another day, but they do protect to some extent. We also know from your very important studies and some other clinical trials that full-dose anticoagulation, if given for other reasons, is most often enough for most of stable patients with ASCVD as well. But your specific question, now is the right time to take it. Low-intensity anticoagulation plus low-dose antiplatelet therapy. I don't think this has ever been studied in outcomes trials. And if you were to ask me last year, I would have been a little bit trembling that maybe we would see a signal for excess bleeds in the subsets who were on aspirin. I was pleasantly surprised not to see that signal. So now, to practically share with our audience, these days I really make a case-by-case basis decision for my patients, because I think we are in a situation where we lack data. Maybe all of us should partner together and do that trial someday.
Yeah.
Would you consider for these people, and I know that you have all this evidence and you are the one who really writes the best reviews in the fields, but would you consider for these people to have, say, 1 aspirin each other day, or going down to a lower dosage of aspirin, like 50 milligrams? I'm aware there's no evidence behind it, but surely now we have all these great studies on low-dose drugs from our French colleagues. We discussed some of them recently here with Isabelle Mahé and Professor Couturier. Or would you say, well, either we go for full dose aspirin in Europe, it's 100 milligrams a day, or we do not give them any antiplatelet treatment at all?
That's another great question. First, let me give shout out to another good friend and colleague, Laurent Bertoletti, who is running the BAT VTE trial. So we are going to have more information there in a couple of years as well. But that's in the setting of acute venous thrombosis. That being said, personally, I prefer not to go off the beaten path unless we are doing a randomized trials. In other words, in my entire practice, I almost never ever use aspirin 3 times a week because show me one randomized trial that studied that regimen. For example, using low-dose DOACs with aspirin or low-dose DOACs without aspirin, we have both of those regimens studied in HiPro, even if it's not a direct head-to-head comparison. But aspirin 3 times a week, I don't know of outcomes trials that used it. Maybe some PK/PD studies, but not outcome trials. So I prefer not to do that. But the exact question of which patients benefit from low-dose DOACs plus aspirin, which patients benefit from low-dose DOACs alone, unfortunately, I don't have the answer.
Not yet.
So I have another question. You show the criteria before in your slides for high risk recurrence of VTE, and there were also chronic inflammatory or autoimmune disorder. So what was the definition of a chronic inflammatory or autoimmune disorder? Because I think there's a big range for high risk or low risk autoimmune disorders, like Hashimoto thyroiditis is also autoimmune disorder. So what was the definition exactly for this study?
That's another good question. The short answer is it was at the discretion of the enrolling clinician. The one thing that's very important that I have to highlight, of course, that would not be the right population, is thrombotic antiphospholipid syndrome. Conversation for a separate day, and we and others have published on this. I strongly prefer to avoid direct oral anticoagulants, let alone placebo in those patients. That I would not consider provoked venous thromboembolic disease. But what we were specifically talking about were the likes of inflammatory bowel disease, the likes of rheumatoid arthritis, Sjogren's, or other similar conditions which per se do not have direct evidence or strong recommendations to consider lifelong anticoagulation just because of them, even though all of us are kind of worried in our minds that these patients have higher risk. There is no firm data before HiPro that I was aware of that if they had provoked VTE, say after a surgery, they would need to be on lifelong anticoagulation. So that's how we define chronic inflammatory conditions.
Yes. Thank you. And another question. We see the risk factors like body mass index above 30 and other risk factors. So can you imagine what will happen after the 12th month? Because we see the population with the 12-month anticoagulation a lot better than the one with the placebos. So usually the most risk factors won't change after 12 months or cut. So most people have body mass index above 30 for more years or even for lifelong. So what do you think how we should handle this?
Another great question. I'll take it 2 ways. Number one, as I shared, from a clinical standpoint, when we make decisions for these patients with enduring risk factors, that is reviewed during longitudinal clinical follow-up. So when we get to see them and recommend, for example, low-intensity anticoagulation for a little while, the next year or next 9 months, however time that it is, that we see them again, we reassess those risk factors. And for example, if obesity has been modified, we will learn that the risk is also coming lower and we can have a different conversation with them. For the research side of it specifically, Greg is currently finishing up 12-month post-completion of the treatment follow-up, so-called HiPro Extend. So we are going to have more information in a little while on that too.
And for this extended study, you will continue the treatment, or do you stop treatment after 1 year?
No, the treatment has been stopped, of course, but it's more of a follow-up to see if there is going to be regression toward the mean or anything else noticeable versus
once people are
continued
off
treatment
medication,
effect.
actually. Yeah.
Exactly.
I have 2 or 3 final questions for this webinar. So first would be surely, do you consider doing thrombophilia testing in some of these people? Here in Germany, we have the idea that too much thrombophilia testing is done, and this often yields some results which appear to be somewhat worrisome for people, like heterogeneous factor 5 Leiden or something like that. So my personal approach is to be very reluctant here. But are there people with deep vein thrombosis, pulmonary embolism, in whom you would go for thrombophilia testing even after provoked deep vein thrombosis?
And this is a very good question. First, I'll give you a philosophical answer, and then I'll become more practical. Some people are of the opinion, the more the information, the better, right? But the problem is it's not necessarily true in a practical, real-world setting. Imagine if you were to do whole genome sequencing for all of your patients. Yes, it's good to know of the variants, but for many of them, we may say, oh, this is a risk for this condition, risk for that condition. We don't know how to act on them. And it's possible, it's very possible that we may end up causing more harm than good by doing this, because I consider those also health interventions. If we want to show that they demonstrate benefit, do a strategy randomized trial, show that it helps people live better or longer, then I would be the first to order them routinely. Short of that, now to be practical for the audience, in patients with provoked venous thromboembolic events, I do not routinely perform or recommend thrombophilia testing.
Thanks. That's very helpful, I think, for many of the patients, actually. And when deciding whether or not to go for prolonged anticoagulation, do you do this decision rather from a clinical point of view, as you actually explained to us, or do you use some of these calculators and risk scores that are available?
Another very good question. And first, let me commend people who created those risk scores. Part of the challenge is some of the older versions, like the scores that we had even conflicting information for the very variables that were included, like agent 6. Some of them were suggesting they increased the risk. Some of them were suggesting they're associated with reduced risk. It's because of how the models were developed. Things like VTE predict are a little more accurate. I think it's reasonable to consider them, but personally, I base much of my practice off of clinical trials when possible, and because I'm not aware of clinical trial-driven risk score incorporation, I do not use them in everyday practice. But in a case-by-case basis, if I run into trouble, I use them to inform patients and do shared decision-making.
And here comes my last question. Looking to the future, end of 25, what are your thoughts on the future of factor 11 inhibitors? So we have seen the last 2 or 3 years, lots of enthusiasm. The last 12 months actually have been rather disappointing. You are aware of all this data. So what do you expect for 26, for 27? Will they really become clinical importance?
This is such an interesting comment to end with.
That's why we ask you, actually. Yeah?
I think there has been a lot of interest in them because for long people have been looking for agents that can safely reduce thrombotic risk, or in Jeff White's words, dissociating thrombosis from hemostasis. Problem is, as you mentioned, some of the clinical trials that came out, including phase 2 and phase 3 studies in AFib, suggested a potential lower effectiveness compared with DOAC. Some others, including for patients with embolic stroke of unclear source, or for patients with dialysis catheter, which you are the expert about fistulae, actually, I have to say, they failed to prove benefit. So I am a little skeptical, and I shared my perspective in a editor's note in JACC a few months ago. But I would love, for the sake of patients, that at least there are some subsets of people who benefit from them. And there was some recent studies published in Lancet, ROXY VTE 1 and 2, which again brought some hope. but I think we really have to be patient, have the totality of the data, and then we would be better positioned, maybe to discuss this in a year or two. An alibi for me to see you again.
Well, this was wonderful. Thanks so much. And it's very easy actually for us to say goodbye, because we will say hello very soon again when we discuss the aquatic study by Dr. Didier. But for this time, thanks so much, and looking forward to meet you again. Thank you.
Thank you.